Hello everyone. Am I audible to all?
Yes, ma'am.
Yes, ma'am.
Okay, thank you so much. And thank you so much for joining our webinar on Insights into Breast Cancer Research, what we know and what we don't. I am Swagatika, your coordinator for this enlightening session. And it is a pleasure to welcome you all. Our event is proudly presented by Heredity Biosciences, a leading biotech company and research center in Odisha and Guwahati. Before we dive into the heart of today's discussion, I would like to introduce our distinguished speaker, Dr. Abhijith from Princess Margaret's Cancer Center, Toronto, Canada. Dr. Kuttanamkuzhi is a prominent figure in breast cancer research, and we are fortunate to have him share his expertise with us. Thank you, Dr. Kuttanamkuzhi, for gracing us with your presence for the second time. Your support is truly appreciated. I also want to take a moment to introduce our esteemed convener, Dr. Gopal Purohit, the CEO and co-founder of Heredity Biosciences. Dr. Purohit is a visionary leader who has made significant contribution to clinical genomics and infertility research. His dedication to advancing scientific knowledge and patient makes him a guiding force in our organization. And before we move forward, let me share some information about today's schedule and instructions. Please listen carefully. We kindly request all participants to stay until the end of the webinar. Following the conclusion, a feedback link will be provided for you to share your thoughts and suggestions. Please ensure that your feedback forms are fully completed to be considered for certificates. We value your input and your cooperation is greatly appreciated. During questionnaire session, we ask that you maintain discipline and respect for others' opinion to facilitate a smooth and productive exchange of ideas. Without further delay, I am pleased to hand over the stage to our director, Dr. Gopal Purohit. Once again, a warm welcome to all the participants. Let's make the most of this educational opportunity and learn together. Thank you, and over to you, Dr. Purohit.
Good evening, everyone.
Very good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Very good evening. I trust my slides are visible to all.
Yes, sir.
Yes, sir.
Yes, sir.
Okay. Thank you, Sushree, for thank you for your kind introductions. I extend a heartily welcome to each of you join our distinctive webinar today. I am Dr. Gopal Purohit, CEO and co-founder of Heredity Biosciences. It is a genuine pleasure to have you all here with us. Today's webinar explore topic is Insight to Breast Cancer Research, what we know and what we don't. So despite step in understanding risk, treatment and genetics, significant gap remain in comprehending and universally treating this complex disease. In this webinar, we will explore the critical gaps and advancement in breast cancer research. So now, allow me to extend my deepest gratitude to our esteemed guest speaker, Dr. Abhijith Kuttanamkuzhi, postdoctoral fellow at the Princess Margaret Center, Toronto, Canada. We are immensely grateful for your acceptance for our invitations for the second times. The entire Heredity Biosciences team is genuinely appreciative of your presence and expertise. Thank you, sir, for your valuable contributions to today's webinar. Now, ladies and gentlemen, fasten your seatbelt as you embark on this accelerating journey into this awareness of breast cancer research and what you know and what you don't. Today's webinar highlights on breast cancer research, a leading cause of women's death globally. Early screening is crucial for better outcomes. Breasts undergoing many cell cycles are prone to genetic mutations. Here, our guest of speaker will brief how breast cancer starts, how it's diagnosed, and current treatments. Classifying breast cancer helps predict survival and guides therapeutic like chemo, radiations, targeted therapy, and surgeries. To improve treatments, we need a deeper understanding of how breast cancer begins and progresses. Research shows changes in the breast cancer development is fuel cancers. So now, therapeutic like chemotherapy offer hope to better prevent survival by combining treatments. To know more about this breast cancer research, 1 in 8 women face the risk of breast cancer in their lifetimes. So making it a most prevalent cancer in women after skin cancers. So per the American Cancer Society that mentioned for that. In 2023, an estimated 293,790 new cases will find out it and are anticipated in US women with 2,800 in men. Globally, in breast cancer effect, 1 in 4 women diagnosed with a cancer and its impact in especially stuck in India, where mortality rate are higher than the coverage, accounting for over a third of women cancer-related death. This disease is accelerating in both rural and urban areas part in India, with late-stage diagnosis affecting more than half of Indian women, making breast cancer and primary cancer in Indian women closely related by the cervical cancer, together accounting for nearly 40% of female cancer caused in 2020. So now, where breast cancer starts? Breast cancer development is influenced by multifactor factors influencing genetic predispositions like BRCA1, BRCA2 genes mutation and a family history of this disease. Lifestyle elements such as age, obesity, and hormone influence play vital roles, with older age and obesity correlated to increased risk, while early pregnancy and extended breastfeeding can mitigate it. Conditions like diabetes, essential hypertension, and hormonal-related treatments may impact susceptibility to the disease. Recognizing symptoms like distinct lumps, changing in nipples, appearance of or discharge, breast swelling, or unexplained tenderness is crucial. This sign, when noticed, immediately medical attentions for evaluations and early interventions, undergoing the importance of regular screening and awareness in combining breast cancer. And the breast cancer can originate from various parts of the breast, commonly starting in the milk carrying duct or the milk producing glands. Less common type like phylloids, tumors, and angiocarcinomas exist, while carcinoma and lymphomas, although occurring in the breast, are not classified as typically breast cancers. Numerous risk factors contributing to the development, including family histories, previous non-cancerous breast limbs, dense breast tissues, aging, lifestyle choices such as diet, smoking, alcohol consumptions, as well as factors like radiation exposure from medical aging and obesities. Hormonal influence, notably like estrogen exposure due to early onset of periods or late menopause, also elevated risk of extending the body's exposure to estrogen. Understanding the risk of factor is vital in early detections and prevention strategies against breast cancer. So once again, thank you, Dr. Abhijith Kuttanamkuzhi, for gracing us with your presence today. We greatly appreciated your time and knowledge. Now, audience, before we begin our webinar and introduce our esteemed guest, allow me to provide a brief overview of Heredity Biosciences. Heredity, the name, established in 2018, and it is reconstructed as a Heredity Biosciences in 2021. Our company has become a key provider of research and training services for hospital sectors, life sciences institutes, and pharmaceutical companies. It is a trusted name in the medical and scientific communities. We oblige our reputations to a team of experienced scientists and research professionals versus in the life sciences, healthcare, and analytical services. Our dedications to quality in mirror in a robotic national advisory boards or diverse team, including professors, doctors, and scientists, specialized team like providing for these cost-effective solutions using frontline technology, serving both Indian and global life sciences research, clinical sector, and industries. Existingly, our collaborations with a Heric Life Sciences Private Limited mark as a significant steps, promising enhanced capabilities and groundbreaking advancement in the life sciences and healthcare research sectors. Together, we aim to determine impactful innovations in this field. Heredity Biosciences proudly operate from two locations. Our main office on Mayfair, Lagoon Road, Jayadevia, Bhubaneswar, and newly branched in Guwahati, Assam, established last year. This expansions mark a substantial milestone, so significant progress and growth of our company. Not only does it enhance our capabilities, but also it present existing opportunity for partnership with establishing institution, professional scientists in these areas. We are genuinely excited about the potential in growth field for the forecasting and meaningful collaborations, collective contributions to advancing in the field of life sciences. At Heredity Biosciences, our core for turnaround specialized service in this life sciences and healthcare, particularly dedicated to research and training. We prioritize excellence in two key areas like life sciences research and healthcare research services. In life sciences research services, our expertise fabrication in genomics, proteomics, and metabolomics, supported by advanced laboratory facilities. This enables us to deliver comprehensive solutions not only to the client in the Odisha, but also across India. We are focusing ensuring the nationwide accessibility and conveniences. In the healthcare research services, we investigate into a crucial research focus domain essential for advancing medical understanding and enhancing patients' outcome. Our service incorporate clinical microbiology, infectious genetics, and cancer genetics, fertility genetics, conventional PCR-based DNA studies. So for further details and to visit on our website, so details explore to the website is available. Now we will move on the Heredity Biosciences training and training part. So we are highlighted for the training and research part of Heredity Bio Academy. At Odisha's leading training institute, we are proud to offer comprehensive hands-on experimental research training to students and professionals. At Heredity Biosciences Academy, we provide various modules to cater to diverse interest and field of the life sciences student and professional. These include clinical microbiology, clinical hematology and genetics, molecular biology techniques, advanced molecular biology techniques and recombinant DNA technology, clinical microbiology, nanotechnology and genetics, food microbiology and genetics, and many more modules are there. Our aim is to equip the participants with the necessary knowledge and practical skills and hands-on skills to require, so they are chosen to area to their expertise. Furthermore, we are excited to announce to some of the specialized modules. Last 2 months we are already announced. These include clinical embryology part, male infertility, histochemistry and immunohistochemistry, qPCR for genetic diagnosis. These frontline modules are designed to address the growing need and advancement in the field of biosciences professionals. For more information, we also updated to the websites also. Now, we will move on the Heredity Biosciences infrastructure facilities. So, Heredity Biosciences take pride to providing exceptional infrastructure facility to support the training and research endeavors to all the participants. We invite each and everyone to visit our central facility and witness the following features like world-class centralized air-conditioned laboratory, high conductivity, well structures, laboratories also, and Wi-Fi environments, complete research learning facility, well-trained and experienced trainer and demonstrator, complete hands-on usual experimental exposure, publication assistance, and sometimes we are placement assistance also to the students. We extend an open invitations to all invited interested individuals to visit our central facility and witness the exceptional infrastructure, supported our research and training activity, meet one-to-one to our trainers. Trainers they will be guide you. So we are confident that you will be impressed by the resources and opportunities available to enhance your scientific pursuit for the career. So in the last 5 to 6 months, Heredity Biosciences has collaboratively sustainable milestones reached into it, and particularly in using biosciences students and life sciences students and healthcare professionals. Some key highlights including conducting intensive 1-day, 2-day training sessions and more briefing to benefiting about 700 to 800 students completed to these programs. Moreover, short-term and long-term internship programs have successfully completed more than 500 students, providing complete hands-on experience and individual exposure across the diverse research areas. These programs aim to short-term skills and development and expand the participants' understanding. They will be utilized to the career, one-to-one learning facilities, empowering them, skilled them for the future endeavor in the biosciences field. So over the 3 to 6 months, Heredity Biosciences has truly dedicated all the students, facilitating to the placement opportunity for the student, resulting in numerous success stories. Many students have completed interviews with the esteemed organizations, while ongoing placements opportunity are still underway for the students. We extend heartfelt congratulations to students and wish them to the prosperous and fulfill their career journey. So, Heredity Biosciences have repeatedly initiative for the research and publications, assisted in-house publications. So now we have an in-house publications, 20 to 30 publications, and some of the papers, publications also uploaded to the sites. And we are collaborating for the different healthcare research institutions as well as for this license institutional research institutions, and published for the papers. And 3 patents right now we already have to the Heredity Biosciences. 2 patents already have ongoing processes. Now, ladies and gentlemen, it is to the time for the introduce of our guest. It is my great pleasure to introduce our esteemed guest speaker for today's webinar, Dr. Abhijith Kuttanamkuzhi, currently serving as a postdoctoral fellow at the prestigious Princess Margaret Center, Toronto, Canada. Dr. Abhijith's academic journey reflects a pursuit of excellence and dedications. Her and his dedicated doctors of philosophy on oncology and cancer research from the esteemed Indian Institute of Science and Education Research, Pune. Prior to this, he completed his master and bachelor degree in biotechnology from Ami School of Biotechnology. Throughout his academic tenure, Dr. Abhijith has a collective individual's research experience in renowned institutions, particularly he served as a summer research fellow under the guidance of Dr. Divyan Haldar in the lab of chromatin biology and epigenetics, founded by the Indian Academy of Sciences. Furthermore, he contributed as a summer intern at the Center of Indian Fingerprinting and Diagnosis and completed a research internship at the Indian Institute of Technology, Bombay, under Dr. Santanu K. Ghosh. His expertise extend to wide area of encompassing preclinical studies, stem cell research, biology, cell and gene therapies, and many more. Dr. Abhijith has received several honors recognizing his contributions, including the IITB IRCC Research Fellowship Award and the prestigious award of his presentation and estimate conference. Dr. Abhijith's groundbreaking research has explored various facts of breast cancers, notably investigating the altered expressions of the anticipated proteins API5 and its impact on breast tumorigenesis among their significant studies. A multifactorial researcher, Dr. Abhijith brings expertise in silico, in vivo, in vitro methodologies to his project. He is skilled in preclinical model developments, targeted identification and validations, big data analysis, and stem and progenitor cell therapies showcase his commitment to advancing scientific knowledge and addressing critical challenges in cancer research. As an enthusiastic cancer research fellow, Dr. Abhijith Kuttanamkuzhi looks forward to an impactful career in preclinical and clinical research, pioneering work in cell and gene therapy and innovative biologies. Now, let's extend a warm welcome to Dr. Abhijith as we eagerly anticipate the invaluable insight he will share in today's webinar on insight to breast cancer research, what we know and what we don't. Thank you for your joining us, Dr. Abhijith, and we were eagerly waiting for enlightening sessions today. This is our team Heredity Biosciences. I truly acknowledge each and every members to appreciated my team members to the best effort every day and night. They are working the research and activities and the reflections of this result into that. So thank you.
Thank you, Dr. Purohit. I think I can share the screen, right?
Sure.
Yeah, thank you. First of all, thanks a lot for the warm welcome, Dr. Purohit and Sushree. It's been a very nice experience last time in the previous session, and I really look forward to having such a great session this time as well. Very, very thanks, Dr. Purohit, for a very nice introduction, and it's been a pleasure to be in this discussion sessions. Let me just share my presentation. I hope you can see it. Is the presentation visible?
Yes, sir.
Okay, thank you.
Yes.
Okay, thank you. Very good evening to everyone. As Dr. Purohit said, we'll be discussing about some insights into the breast cancer research. And as he said, I'm a postdoctoral fellow currently working in Princess Margaret Cancer Center in Toronto, Canada. And my work mostly focuses on understanding the different DNA damage dynamics and cell cycle related changes that happens during the early stages in the breast cancer, and how it is how these changes are coordinated with the changes in the breast morphogenesis. My work would also be kind of slightly reflected in today's talk. So let's start looking into this, where So in today's talk, we will be mostly focusing on what are the current understandings that we have in the field of breast cancer research as such, and what are the things that we know about it, and what are the areas that we need more information, or we still don't know the details into it. So before going into the breast cancer as such, first we will look into what a human mammary gland looks like. So in a human mammary gland, as you can see over here, the two main regions of interest are the lobules and the ducts. So the lobules are basically, that's a cluster of something called as acini. So the acini are nothing but simply a bilayered spheroid-like structures. And these spherical structures are clustered together to form something called as lobules. And these lobules leads to ducts that finally takes the milk to the nipple. So that inside the ducts and the lobules, in the mammary gland, we have a bilayered epithelium. What I mean by bilayered is that there is a basal lining of cells, which are called as basal cells, and there is a lining of cells called as luminal cells, which are inside that. So the basal cells act as an attachment to the extracellular matrix and the luminal cells. And the luminal cells are the ones that secretes the milk into the empty lumen that is in the center. And this milk is then collected to the duct before going into the nipple. And as you see over here, the two major lineages in the breast epithelium are the luminal lineage and the basal lineage. So what I mean by lineage is basically the two types of epithelial cells that are present in the mammary gland epithelium. And these two lineages are basically originates from a mammary stem cell, and they forms the progenitors called the luminal progenitors or the basal progenitors, and they matures into the mature basal cells, which are called the myoepithelial cells, which are basically the lining, and the mature luminal cells, which can be alveolar luminal cells or the ductal luminal cells, which basically differentiate between the location at which these cells are present. So now having an idea about what the mammary gland looks like and what are the main epithelial cells that are involved in this, we can just have a brief idea about what the breast cancer will look like. So as Dr. Purohit already mentioned, it is the most common cancer in women, and that's the major cause of death by cancer in women as well, around the globe and in India. And it's mostly very often diagnosed at an age above 50. It has an increase in incidence as the age increases. And there can be different varieties of breast cancer, which we will delve into and have a basic idea soon. As Dr. Purohit mentioned, and as most of us would know, early detection and better treatment strategies are a need for the hour. So now what happens in a breast cancer scenario inside a breast mammary, human mammary gland? So as I showed you earlier, this is how a normal mammary gland would look like. While when there is a tumor formation, they can form tumors either in these lobules or in the ducts. Now, what you see over here is something, it's an invasive cancer. It's a cross-section of a tissue from an invasive breast cancer patient. And as you can see, you don't see any structures like what we saw just in the previous slide. Like you don't see any bilayer, you don't see any lumen, you don't see any ducts. What you see is like a huge population of cells. And this is basically like where the invasion have already started and the cells are spread across the tissue. And what are the ways you can screen for a breast cancer? So it all starts from an initial breast exam. And in the initial breast exam, if the physician finds there is any abnormalities, they ask the patient to undergo any breast ultrasound or a mammogram. And this gives us more insights into if there is any lesions or if there are any mass that are present in the mammary gland. And then if there is again any serious things that the physician has a concern about, they ask the patient to undergo an MRI and a biopsy. And this, after the biopsy, is when they decide like what are the treatment strategies and what are the ways that the physician can use for treating this particular cancer. And that includes first figuring out the staging, and then we go into other treatment modalities, figuring out what are the type and all those things. And if you look into the progression of breast cancer, as I earlier said, in the mammary gland, you have these lobules and ducts, and the cancer can affect either lobule or the duct. And what we know about the progression of breast cancer is that it all starts as a benign lesion. And what I mean by a benign lesion is that in the normal epithelium, when one of the cell or a few of the cells undergo transformation events, and what I mean by transformation event is that that cell acquires ability to proliferate and at the same time inhibit the apoptotic signaling, so that these cells just continue to proliferate even if there is a DNA damage getting accumulated, even if the cell is not supposed to proliferate, or even if it is activating any immune responses as well. So all this causes something called as atypical hyperplasia, where you will see this small number of abnormal cells. And it's very hard to detect the cancer at this stage because you do not actually have any particular lump, or if there is no any kind of lesion that have occurred in the breast. And once it advances from this stage to something that is malignant, so in the malignant, it starts with something like the in situ cancers. So what I mean by in situ is, as the name says, it is present, it is still confined into the duct wall. So the basic duct wall or the lobule, the acini structures are there, but the lumens are getting filled up. So there is, you will start seeing smaller amount of lumens, and there are more cells accumulating the lumen. And when this stage further advances, where the cells finally do not have space to occupy inside the lumen, and they still continue to proliferate, they start invading out of the breast wall, the duct wall. And once that invades out of that, that is when you will see a mass of cells spreading across in the entire mammary gland without having any specific structure. And these cells can then be a metastatic cell as well if they enter into the lymphatic system or into the blood vessels. Broadly characterizing the breast cancer, if you look into the types of breast cancers, the ductal breast cancers and the lobular breast cancers, which are the two major cancers types in breast. And there are some rare cancers, which includes mucinous breast cancer, which originates from the mucin cells, and then inflammatory breast cancer that's associated with an enhanced inflammatory response. And then there is mixed tumor breast cancers. This is something where we exactly have no idea where we can place this cancer. Can it be ductal? Can it be lobular origin? Or can that be more of inflammatory responses and things like that? And if you further try to understand what are the subtypes in the breast cancer, that can be majorly carried out using two methodologies. First one being the hormone receptor-based methodology. The hormone receptor-based methodology, as the name says, looks into two of the major hormones, which are the estrogen and progesterone. And the receptors being present or absent makes them as the specific subtype. Along with the estrogen receptor and the progesterone receptor, there is something called as human epidermal growth factor 2 or HER2 receptor, which is also being considered. So we have three receptors whose expression or absence of expression helps the clinicians to figure out what subtype this cancer can be associated with. So those patients who have a ER meaning estrogen receptor, and PR meaning progesterone receptor, and HER2 is human epidermal growth factor 2 receptor. Now ER, PR positive are hormone receptor positive, and then there are HER2 positive cancers. And if a patient have none of the receptors, they will be categorized as triple negative breast cancers or TNBCs. If you look into the presence of these in the population of people having breast cancer, almost 73% of all breast cancer cases are something that belongs to the hormone receptor positive, HER2 negative. And this actually have the best prognosis, and it's one of the most common subtype in every race, age, or poverty level. And around 13% of all breast cancer cases are extreme basis or triple negative. They do not have any hormone receptor expression. They do not have a HER2 expression. And this is one of the worst, one of the worst prognosis. And they have some specific association with, for example, a non-Hispanic blacks having a higher rate of this subtype at every age and poverty level. So such correlations are also being present for certain subtypes as well. Now, around 10% of all the breast cancers are of HR positive and HER2 positive. And this is still evolving subtype where we still do not know a lot of things, like what is the epidemiology, and is there any correlation to specific race, or is there a specific correlation to some kind of ethnicity and age or a poverty level. We still don't know about that. And around 5% of all breast cancer cases are hormone receptor negative and HER2 positive, which means it's only HER2 positive. And this is one of the lowest that's present in all the races and ethnicities around the globe. Now, the other method of subtyping is quite like an additional layer towards the hormone receptor based subtyping. And this is called molecular subtyping. And this can be like the cancers will be subtyped as luminal A, luminal B, HER2 enriched, or basal-like. Now, the genetic profile for luminal would be having a higher luminal cytokinins, which is basically the markers that are associated with the luminal lineage in the breast, which we spoke about in the first slide. And then in the B subtype, we'll also have an enhanced proliferation related genes. And the HER2 is pretty much what the HER2 subtype in the hormone receptor based classification. And in the basal subtype, we'll have basal cytokeratins. Again, these are the cytokeratins that are basically markers used for the basal subtype, that are only cytokeratins that are only present in the basal subtype in the normal human mammary gland. Now, if a cancer patient has these basal cytokeratins being highly expressed, there is a chance that cancer can be subtyped as a basal breast cancer. Histologically, this is how the 4 different subtypes looks like. In the luminal A, you have ER positivity, and same in the luminal B, where the luminal A is of a higher grade and luminal B is of a, luminal A is of a lower grade and luminal B is of a higher grade. And HER2 is usually a high grade cancers, same like the basal. And basal actually also have sheet-like histological phenotypes, and that you can see over here, like you will just see a spread of cells all across the tissue. More than that, there are other surrogate markers that are associated with these subtypes. For example, the luminal A will always have a ER, a PR that can be positive or negative, PR meaning progesterone receptor, ER is estrogen receptor. And HER2 would be negative. And they also have a low Ki67, where the Ki67 is a proliferation marker. Now, luminal B usually have a weaker ER positivity, and again, a PR positive or negative. And HER2 can also be positive or negative. But what makes it very different is a very high proliferative index with a very high Ki67 levels. The HER2 has a HER2 being expressed, and ER or PR can be positive or negative. Now, the basal subtype, as the name says, it doesn't have ER, PR, or HER2, but they have cytokeratin 5 or cytokeratin 6, which are basically basal cytokeratins being expressed and EGFR being positive. Now, if you look into the prognosis of a patient, the luminal A usually have a good prognosis and luminal B having an intermediate prognosis, where HER2 and basal have one of the worst prognosis. Now, we'll go into the therapies because there are some of these subtypes actually says that there is a targeted therapy being available, and while some of them does not have the possibility. We will be going into the therapeutic aspect in the later part of the slides. Now, after having understanding about what are the type of breast cancer and what is a subtype of breast cancer, the next thing a clinician need to do is to understand the stage of the cancer. So in the breast cancer is basically carried out based on 3 factors, which is also called as T&M staging, where T stands for the tumor size, And N stands for the lymph node, the number of lymph nodes that are affected by the breast cancer. And M is a distant metastatic sites. Now, if a patient actually have a very small tumor, like which is inside the gland and it is still having spread across, and there is no lymph nodes being affected, none of the other organs are affected, the patient would most probably be a stage 0. While if the tumor size slightly increases and still it's less than 2 centimeters, that patient would be in stage 1. While the stage 1 still will not have any lymph nodes being affected, and it would not have spread to any other organs other than the breast. Now, stage 2 is when the tumor size is something between 2 to 5 centimeters, and there is a possibility that one or a few of the lymph nodes are affected. And however, it still wouldn't have spread outside the breast area. If the cancer grows further, and if it is 5 centimeters and larger, and there are multiple lymph nodes that are affected, and it has reached the muscles and the skin in the breast area, those patients will be classified as stage 3. And however, in stage 3, it will still not have gone or metastasized into a distant site. While any patient who have a distant metastasis would most probably belong to the stage 4. Now, one of the major issue in developing countries, including India, is that at a majority times, breast cancers are diagnosed at the stage 3 or 4, which are actually have advanced, and it's extremely difficult to have a targeted therapy or get a time enough to figure out the methodologies and treat the patient. So that's why it is always said that it is very, very important to have early detection. We need to figure out methodologies. We need to have continuous exams to make sure that we detect them at least in stage 1 or 2. Now, having the cancer staging being done, the other part of understanding a breast cancer would be to do the grading. In the breast cancer, the grades can be divided into 3, grade 1, grade 2, grade 3, where grade 1 having the best prognosis stance and grade 3 having the worst prognosis stance. And this grading is completely based on the histopathology, and the pathologist actually looks into the tissue and figures out what grade this cancer patient would be belonging to. The grade 1 basically would still have more than 75% of the tumor in a glandular structures. So for the example, this is a grade 1 cross-section of a grade 1 breast cancer tissue. Sorry. In this, you can very nicely see that there are these empty lumens. You still have the glandular structures, and there is no invasion, or there is nothing much like the cells are completely spread in the tissue. Now in grade 2, we will have around 10% to 75% forming a glands. But at the same time, when you compare between grade 1 and grade 2, you will see a little more differences if you look closely into the nucleus. Where in grade 1, the nucleus is still more or less uniform with small nuclei and have a size that is pretty similar to the normal breast epithelium. And they actually also have a smaller number or smaller percentage of cells that are mitotic. So if you see around 10 fields in a slide, you will have around 7 mitosis happening over there. That means there is lower proliferation happening. Now in the grade 2, we will have cells that are larger in size, and they also will have an open vesicular nuclei, and it will be more visible, suggesting that there is more, the nucleus is more larger and the DNA is more accessible. And that also points towards the possibility of having enhanced proliferation, DNA replication, and protein synthesis being happening. And it also shows increased mitotic count, where around 18 to 15 mitosis per 10 fields of a slide that you look into. And grade 3, as you can see over here, this is when you mostly would not even have any glandular structures, and it will only be a mass of cells. And the cells with vesicular nuclei with a very strong nucleus that you can see we can clearly mark out the nucleus from there. And the size and the shape of the cells would have been greatly varied. Like you cannot even say, looking into that, this belongs to the breast. And the mitotic counts would also be pretty high, with every 10 fields showing more than 16 mitosis. And this is having the lowest prognosis, because by this, actually the cells have acquired enough mutations and changes, and the tissue have undergone a lot of damages, and it's extremely difficult for blocking its further advancement. So having an understanding about what are the types of breast cancer, we will now try to understand what can be the risk factors, or what can be associated, or the causes, or the things that will favor the breast cancer initiation and progression. So some of the lifestyle factors that very commonly are associated are smoking, alcohol, physical inactivity, body mass index, and etc. But what's more interesting, because these are things that we still are always been analyzed or studied based on coexistence figures. Like you look into the percentage of people who are having, for example, who have smoking habit and the occurrence of cancer. So it's just a correlation, and there are papers that suggest positively to this and negatively to this. And we obviously need further understanding exactly how these things are stimulating breast cancer, or how these would be exactly helping the progression of breast cancer. While at the same time, something like pregnancy and breastfeeding are also being correlated with better prognosis. And what's one of the major interesting things with regards to the breast cancer research is when it comes to the different genes that are mutated. So now, as I mentioned in my first slide, there is a category of breast cancer that are familial breast cancer or hereditary breast cancers. So in the hereditary breast cancers, it's only around 10 to 15% of all the breast cancer cases actually forms the hereditary breast cancers, and this is where we know there is a known mutation being present that's been there in the patient, and we believe that it's associated with a familial history. Now, majority of the hereditary breast cancers have a mutation in BRCA1 or BRCA2. And in the BRCA1 or BRCA2, taking almost 60% of all the hereditary breast cancers, we also have a lot of other genes that are associated or that are having mutations, which can also trigger, which can also be associated with breast cancer. And if you see, one interesting factor in this, for example, are that if you look into the genes, they are mostly associated with a pathway that is cell cycle and DNA damage response. And it's for example, the BRCA1 and BRCA2 are basically associated with the DNA damage response that happens as part of the double strand break repair. And P53, which is a master regulator and is very often also mutated in breast cancers, is a major player that regulates the cell cycle progression. And it regulates both the G1S transition and the G2M transition. And the other factors such as ATM, ATR, CHEK1, CHEK2 are also major players involved in the cell cycle and DNA damage response. So why cell cycle and DNA damage response is probably a major target, or it's a major factor that is associated with breast cancer initiation and progression. So this question have been there in the field, and a couple of things that makes it pretty understandable is that if you look into the mammary gland morphogenesis, in the lifetime of a female, the breast mammary gland actually undergoes numerous number of cyclical proliferation and apoptosis. For example, if you look into the mammary gland morphogenesis, in a female, in the embryo stage, there will be the mammary gland tree would have initiated, where you will see a small ductal structures being present. And this is when the mammary gland morphogenesis starts. But it pauses till puberty, where in the puberty time, you will have these structures called terminal end buds. So the terminal end buds are actually something that is contains a lot of fibroblast cells, and there's a lot more proliferating cell, and it forms something like a bud-like structure, which is basically going to proliferate and spread across the breast area. Now, when the stage of puberty gets over and adult age starts, that is when there would be an expansion of these terminal end buds, and that's the terminal end buds and the ductal tree starts expanding in the mammary gland. And once it starts expanding and accumulating or being like spread inside the breast, and this then waits till a pregnancy. And during every ovulation cycle, this ductal tree undergoes a proliferation and apoptotic cycle. And during pregnancy, this proliferation enhances manifold. There will be a very huge increase in the proliferation differentiation, where you will have the luminal progenitors forming the mature luminal cells, and there will be more vasculogenesis being happening. There will be more and more ductal trees being expanding. The entire breast area would be covered with the ductal tree. And once the lactation starts, this becomes secretory and the milk secretion starts, and that is when it will be at its peak of the proliferative stage and at the peak of its secretory phase. Once the lactation stops, and then there is something called as involution. And involution is basically apoptosis and progenitor regeneration that happens in the mammary gland, and this goes back to this state so that it is ready to do the next round of proliferation and apoptosis during the next pregnancy. So this, if you look into it, you can clearly see that how regulated this entire process should be, because it's a continuous proliferation and apoptosis that is being happening, and during pregnancy that enhances manifold, and you see more of differentiations being happening. And we also need to make sure that the progenitor cells pool is still maintained, and at the same time the cell's integrity is also maintained. And that is why cell cycle and DNA damage is very important, and the regulation of that and how well your genome integrity is maintained is extremely important in the mammary gland. And any changes in this, any deviations or any loss mutations in the genes that are associated with this cell cycle and DNA damage can actually feed into the transformation event and breast carcinogenesis. Now, if you actually look into the adult stage, where there is during the ovulation stage, there is a fluctuation in the hormones. There is a first influx of estrogen, and then there is progesterone influx, which based on which we can classify it into follicular phase or the luteal phase. And if you see the mammary gland from a mouse, where the estrus state is basically the follicular phase in mouse, and diestrus is the luteal phase in the mouse, you can clearly see how the mammary gland looks like. So this, what you see image over here, is the entire mammary gland from the mouse being taken out, and it's been stained on a slide. You can clearly see that in the luteal phase, it's been spread, and there is a lot more branching, and there is a lot more density in the mammary gland as compared to the estrus phase or the follicular phase. So there is a huge difference that is happening continuously in the mammary gland during the lifetime. And this is one of the major reason why you see there is a chance of getting mutations in the cell cycle and DNA damage responses being present. So now, having an understanding about the different factors that contribute to breast cancer, the different genes and mutations that are associated with breast cancer, and how breast morphogenesis is important, and the deviations in that, or the mutations in the genes that are involved in it can contribute, we will now try to understand what are the known therapeutic approaches that we have for the breast cancer. So in general, we can divide the therapeutic approaches as local or systemic. A local approach is basically a surgery or a radiation, and this is a more general way of treating cancers. And the systemic therapy is where you have chemotherapy, hormone therapy, and targeted therapies being present. The surgery and radiation the surgery especially is when the cancer is at a very late stage, because then you do not have an option but other than a complete removal of the breast or maybe a partial removal of the breast mammary gland to be done. While in the systemic therapeutic approaches, if you look into chemotherapy, these are non-targeted therapies, and these are more general chemotherapeutic agents that are being used. For example, anthracyclines are something that inhibits the effective DNA repair, and by inhibiting the effective DNA repair, that increases the DNA damage and thereby leading to more cell death. Taxanes is another class of chemotherapeutic agents where it inhibits the cell cycle and causes cell cycle arrest through microtubule stabilization, and thereby preventing the cells to proliferate and thus causing a decrease in the tumor mass. 5-fluorouracil or 5-FU inhibits mRNA synthesis, and cyclophosphamide is a genotoxic agent, and all these basically causes more DNA damage or inhibits cell cycle proliferation and tries to reduce the tumor proliferation. However, these are not targeted therapies. The chemotherapy probably would affect almost every cell in the human body. And it obviously have a strong side effects, and depending on the dosage and how severe your disease is, your life routines and the health lifestyle would be greatly affected. And then there is also a possibility that it can actually cause a second cancer, because as we mentioned, a lot of them actually causes DNA damage. Now, that is where hormone therapy and targeted therapies are coming into picture. Hormone therapy is pretty simple. It only works if the breast cancer patient is belonging to the hormone receptor positive subtype. If the patient belongs to the hormone receptor positive subtype, the hormone estrogen receptor signaling would be functioning there. And when estrogen, the hormone, binds to the estrogen receptor, that causes a dimerization and activation of the estrogen response element, and which contributes to enhanced proliferation. Tamoxifen is a hormone receptor therapeutic agent where it goes and binds to the estrogen receptor, and thereby inhibiting its ability to bind to the co-activator and forming a dimer, and thereby inhibiting the proliferation. This is a very nice targeted methodology, and having the ability to do this in hormone receptor positive cancers actually helps greatly in enhancing the survival chances of those patients. If you broadly look into a targeted therapy, there are other genes or proteins that can also, pathways that can also be inhibited. For example, HER2, there are HER2 inhibitors which are mostly monoclonal antibodies that can also be used as a targeted therapy. Other than HER2 and the estrogen receptor, we also have targeted therapies that are existing for EGFR, PI3K, and then there is KRAS inhibitors, CDK4 inhibitors, and PARP inhibitors being used. Now we'll look into some of the examples of how this actually works, starting with the monoclonal antibodies that have been used against HER2 positive cancers. Again, it can only work in a case where the HER2's positivity is being detected. And if a patient turns out to be HER2 positive, the clinician can recommend using monoclonal antibodies such as pertuzumab, trastuzumab, or lapatinib, afatinib, etc. Now, what happens with these targeted therapy is that, for example, the pertuzumab, it actually inhibits the receptor dimerization, which in the starting phase itself, and thus preventing the activation of the HER2 receptor signal. The trastuzumab actually inhibits one of the downstream element, and if you look into the lapatinib and others, they directly inhibit the downstream tyrosine kinase, while there are two other methodologies that are further enhances this targeted therapy, is a targeted delivery of a highly cytotoxic agent along with trastuzumab. So trastuzumab will definitely goes and binds to the HER2 receptor, and then you will have a carriage along with the antibody, which is a highly cytotoxic agent that will specifically kill the HER2 positive cells, thereby increasing the efficiency. Along with that, there are dual targeting trastuzumab and pertuzumab that are being studied right now, which can also inhibit this signaling activity. However, what happens altogether downstream is that it inhibits the PI3K kinase signaling and it promotes cell cycle arrest. Another targeted therapeutic methodology is targeting the BRCA1 tumors or BRCA1, BRCA2 tumors. So BRCA1 and BRCA2 are genes that are very closely associated with DNA damage response. In a normal cell, it occurs different types of DNA damages, such as single-strand breaks, double-strand breaks, DNA adducts, and oxidized bases, as well as mutations. Now, there are different repair mechanisms that are in place to target these different types of DNA damages. For example, the single-strand breaks are mostly repaired by base excision repair, where the PARP1, along with other PAR-related proteins, activates this signaling, leading to clearing of the single-strand breaks. The double-strand breaks are mostly cleared using two mechanisms: non-homologous enjoining and homologous recombination. The DNA adducts will be cleared by NER and mutations by MMR. We will have a specific look into the DSPs. While DSPs are one of the this is one of the lethal cause of cell death, lethal type of DNA damage that happens to any cell. And based on this phase of the cell cycle, and the cell can determine whether it needs to go through the NHEJ or the homologous recombination. Homologous recombination only works if there is a sister chromatid or a copy of the allele is present within the cell. So that happens during the cell cycle only in the SNG2 phase, where you will have a sister chromatid being present there. Now, on the majorly of the in a cell, NHEJ is the way for repairing a double-strand break. But homologous recombination is actually a error-free repair, and NHEJ is an error-prone repair because it does not have an exact copy of the allele, and it basically just repairs by joining the ends. Now, if you look into the HR, that is where BRCA1 and BRCA2 are involved. They are involved in the major steps involved in the homologous recombination. So in a BRCA1 tumor, what happens is that this particular function would not be happening because the BRCA1 is mutated. So when a BRCA1 is mutated, the homologous recombination won't be happening in the way that it actually has to happen. So they will be called as HR deficient tumors. Now, when the HR is deficient, the cancer cell would be more prone towards using the NHEJ pathway. So what we do is using PARP inhibitors, where PARP goes and binds to single-strand breaks, and the PARP inhibitor actually traps the PARP onto the DNA so that it cannot activate the single-strand break repair, but rather causes a replication fork arrest and then causing a double-strand break. So now there is a double-strand break, and this has to be cleared. The cell has to utilize NHEJ or HR. And if the cell has a double-strand break pathway, is HR proficient, it will survive. But at the same time, if it is HR deficient, it will occur more and more errors as the cell try to proliferate, causing apoptosis, and thereby targeting the cell, targeting the specific cancer cell towards cell death. So this is a very intelligent way of doing this, and it has been greatly helping the BRCA1 cancer patients. However, recently we have a lot of cases that are associated with PARP inhibitor resistance. So the way how the PARP inhibitor resistance is acquired by these tumors is still a question that needs more understanding. However, it is a major concern that we need to be addressing in the current time, because these targeted therapies are some of the only ways in which we can actually improve the patient survival and not cause a lot more other side effects. Along with these targeted therapies, we also have an evolving field of utilizing immunotherapy for breast cancer. And these approaches are still needs a lot more investigations. We still need a lot more understandings. But if we majorly classify, one of them, or some of them, includes inducing an anti-tumor immune response using the T cells and, for example, CAR T cell therapy and stuff like that. And then there are monoclonal antibodies which will direct the tumor cells towards killing. And then the other way is activating the FC-mediated functions, causing the affected T cells to detect the tumor cells and initiating an extrinsic cell death pathway in the tumor cells. And then there is also a field of research that happens where we try to do a combination immunotherapy, where we'll have these different immunotherapeutic agents along with other chemotherapeutic agents or targeted therapies being used together. However, these still needs further investigations, and we still need to understand how effectively we can target the cancer cells in the breast. So if you look broadly, the things that we still need understandings, it actually starts from how the cancer starts. So one of the major things is that we know about the breast cancer is that it's very closely associated with an increase in risk, which is associated with age. So there is, as the age increases, there is higher chances of breast cancer. But then there is something called as menopause that is that actually affects the hormonal activity in a female. Now, how that is linked to the age-associated increase is something we still need to understand. And the next thing is about breast cancer that needs further investigation is the initiation of breast cancer. Are the invasive ductal cancers actually originating in the duct, or is it like there are two events that are simultaneously happening and the cancer forms at a place where it favors more? And what are the role of the hormonal signaling that happens in the initiation of breast cancer? This is also something we need to understand further. We know that there is an association between the cell cycle DNA damage and the proliferation that happens in the breast, and how that can actually help in favoring the breast cancer progression. But we still need to actually connect what mechanism in the hormonal signaling actually is favoring this, because hormonal signaling happens in normal scenarios as well. But how that hormonal signaling goes out of control and there is enhanced proliferation that is caused by the same signaling. Then in the BRCA1 mutant cancer specifically, the BRCA1 mutations are present as a it's been present as a familial mutation, and it can be present from the one generation to the next generation. But it usually happens in a heterozygous state. Only one of the allele has a BRCA1 mutation. Now, the second mutation, the second allele can also be mutated. And what is the trigger for that mutation? Or what, if the mutation happens, what could be the next steps? What exactly happens in the next step is a completely open question that we still don't know. Because one major thing to understand is that there have been studies where people try to cause a homozygous BRCA1 mutation, mimicking what happens in the human system. However, the mouse models that they used do not develop a tumor very soon. It took a very long time of almost a year to develop a tumor in them. And that also was later they had characterized and figured out there can be other mutations that can also be happening along with that. Now, exactly what is the key event that causes this BRCA1 mutant cell to getting transformed? Is it associated with the hormonal signaling? Is it something to do with the extracellular matrix? We still don't know. And then another major concern is most of these familial history and familial studies and the mutation studies are based on an understanding of a population in the western part of the world. Now, we still don't know whether this is actually the landscape of mutations in countries like India, having one of the largest population in the world. Some studies in the Indian population have found that they have a prevalence of non-BRCA mutations over BRCA mutations. So we might need a different set of targeted therapies than what the BRCA mutation dominant Western, the side of the globe needs. So we need much better understanding about the genetic landscape of these cancers in the countries such as India and parts of Africa. And now, as I mentioned earlier, there is also a cause of concern in the drug resistance and recurrence. Around 50% of women affected with the HER2 positive breast cancers present or acquires resistance to the monoclonal antibody treatment. So HER2 cancers were considered having one of the worst prognosis, but at the same time, having a targeted therapy makes it much more manageable. But if the patient develops a resistance to the monoclonal antibody treatment, it is going to greatly affect the survival of these patients. And the PARP inhibitor resistance that I've been talking about. So how mechanistically these are happening, and what can be the modalities that we can use to enhance the therapeutic effects in these scenarios. And of course, we also need better early detection strategies, which can be non-invasive, blood sample based, on genetic mutation profiling based studies. And before finishing, there are one of the major commonly presenting question is that, can we prevent breast cancer? So if you ask that question through, can we prevent breast cancer using drug usage? No, we cannot do that as per current understanding, because it's not something that is caused by single agent. It is not caused by a single mutation or a single pathway. There are a numerous number of changes that happens in the mammary gland. However, there are again studies that says that through diet changes or through different lifestyles, there is a possibility that we can reduce the risk of breast cancers. So what currently we can do is basically to practice self-routine exams, know what is the risk based on your family history. If there is any person in your family having a cancer risk or cancer history, you should be taking more care about that, and visit your doctor regularly and know when to get a mammogram. So that's the only way of catching the cancer in an early stage, so that the chances of further malignant transformation can be prevented. With that, I would like to thank everybody for attending, and I'll welcome for any questions.
Thank you, Dr. Abhijith. So now the open for this discussions. Only for the 2 to 3 questions for the audience sides, because it is too late. Anyone? I think one question from my side.
Yeah, sure.
How does lifestyles include diet and exercise impact breast cancer risk?
I'm sorry, how do?
Lifestyles including diet, exercise.
Okay. Yeah, so this is based on several incident studies and correlating the kind of diet that a set of people follows, and that's been correlated with the presence of or prevalence of breast cancers. So high fatty diet is very commonly found to be associated with increased risk for breast cancers. And if you follow a low fat diet, it's been found that there is a possibility to reduce the risk of breast cancer. So there are some insights that we know from the research perspective, where we know that in cancers, we have a higher metabolic rate. The cancer cells actually have a very high metabolic rate. So they utilizes a lot more energy than the normal cells, because it need to proliferate more and all those, the basic understanding about cancer cells. And that actually makes it utilize a lot more fatty acids and a lot more of the nutrients that are present into these the cells. And utilizing more fatty acid, when the cell starts to favor towards the fatty acid metabolism and things that are associated with that signaling, it actually, if the patient continues to utilize more high fat diet, it actually favors the proliferation and the progression of breast cancer. So that is something that is it's based on in vitro studies that we know that, okay, the cancer cells have these kind of favorable things towards some subtype some part of the metabolic signaling. But we still need whether these things are actually happening in a patient. Like, are these signaling mechanism being activated in a patient who eats a high fat diet? Those things are still open. Like we still don't know those ideas.
So what are the challenges of a diagnosis of inflammatory breast cancer?
The challenges of identifying breast cancer, first of all, the thing is that the first examination has to be done by the patient itself. Like the patient has to first understand if there is a risk and if there is some lump growing or if there is a difference in the breast happening. And then immediately seek a medical attention. Like if you see any abnormality, you need to seek a medical attention. Like it can sometimes mimic like there is a skin changes. It can be something that just there's a lump that is happening. But then what happens is due to the fact that in countries like India, we still have that hesitance towards going into the doctor and seeking a medical attention in these scenarios. And that need to be changed first. And the second thing is that once we have this, we need to have presence of more and more doctors and presence of more and more clinics where we can have this early detection being carried out from a clinical background. Like the patients can just go in and get more better understanding without having to travel a long distance for these kind of specific treatments.
Okay, thank you. So last question, myself. So
Sure.
what is the breast cancer different from man and compared to the woman?
Oh yeah. Yes. So this I saw in your slide also. There is this a small number of men having breast cancer. So again, it is something that's we need further investigation. Like there is no exact idea how that happens because if you look into the embryo stage, both men and women have a small rudimentary mammary gland, the small tree that is being present in both men and female. But since there is an absence of hormonal signaling, that the small rudimentary mammary tree, ductal tree, does not proliferate or does not lead to the terminal end bud formation and stuff like that. But then due to certain reasons, these signals are being acquired. It can be because of things that are associated with the lifestyle. It can be some changes in the hormones. It can also be associated with maybe some other drugs that the person is taking. So there's a lot more reasons, but because we don't have enough sample of patients, we cannot actually figure out what exact reason it is. It can only be, mostly what happens is it's detected and it's either being removed by surgery or there is chemotherapy that happens because we still don't know exactly how the landscape of the men's breast cancer in men happens. Like we have no idea about what are the prevalences. Is there something that is associated with high cancer risk in men? As there is less samples, again, we have no idea. And again, this actually connects back to my first talk that we had, where we would talk about the in vitro tools that we need to develop, which I think would be a major thing that can help in scenarios like that.
Okay, thank you so much.
Thank you, Dr. Purohit.
Okay, audience sides, one questions only. Anyone?
Excuse me, sir.
Hi, somebody.
Yes, sir. Sir, I would like to ask you that you told us about the conventional methods and the non-conventional methods in which the breast cancer is mitigated and treated, right? So, in case of the non-conventional ones, aren't there side effects like PCOS and PCOD because they're involving estrogen and progesterone, like the hormone therapy you told us about? It is involving estrogen and progesterone, right? So, won't that be causing hormone disbalances and leading to diseases which are related to it?
Okay, so hormone therapy is basically targeting the hormonal signaling, the estrogen receptor signaling. If you like, when I spoke about something called as tamoxifen, it inhibits the hormonal signaling. So basically, the hormone therapies are only used in cancer patients who have a estrogen receptor or a progesterone receptor being highly expressed. And in those scenarios, the hormones can actually be a cause for the increased proliferation. So you're basically trying to inhibit those signalings. And of course, there is a risk of being a non-targeted treatment of these tamoxifen or any estrogen receptor inhibitors, because that can also affect the ovary and the entire hormonal signaling. But that's when we need to have targeted delivery of these drugs towards breast. And this is something that's also in studies right now, and really hope to see advances coming from that. And with regards to chances of PCOD and other ovary-associated diseases, yes, of course, any chemotherapy and hormone targeting therapies can be associated with other risk. But then the clinician actually determines between what could be the comparing between the side effects and what can be the positive outcome from the treatment. So which one, based on that weighing, if there is a larger chance or a better chance for treating the cancers using that regimen, the clinician has to utilize that, and the patient would probably be favored with that. And there are other ways, and there are lifestyle changes, there are other things that the doctor recommends so that the patient can minimize the side effects.
Okay, all right, sir. Thank you.
Thank you.
Thank
Very good
you.
evening, sir. Sir, am I audible?
Yes. Yes, Pranam.
Actually, sir, my question is, as you said about the prognosis, that it is 50% prognosis rate is seen in case of HER2 positive patients. I mean to say that monoclonal antibody correlation with the HER2 positive treatment, what we can expect from there? Because yeah, it shows 50% that we can cure, like we can target HER2 positive patients. What exactly the role of monoclonal antibody can play in that?
Okay. So 50% is basically the chance of resistance towards HER2 therapies, basically the monoclonal antibody-based therapies. And this is, as of now, it's still being characterized to understand, is it something that happens because that the cell acquires a different different methodology to still activate the HER2, or is there a different signaling that is being activated even if the HER2 is inhibited? So the monoclonal antibodies is still one of the first line treatment in breast cancers where there is HER2 positivity, because that is still considered a very targeted therapy. And until and unless the patient shows any symptoms of that it has been having a resistance, we cannot exactly, or the clinicians exactly cannot figure out there is a resistance to it, and so that they cannot directly go into a different treatment methodology. Now, if a patient responds to the monoclonal antibody, it gives you a very nice increase in the chances of survival, because that actually very specifically inhibits the HER2 positive breast cancers, because the number of enhanced expression of HER2 would only be present in the breast cancer cells that have the HER2 positivity, or those cells that increases in the expression of HER2 receptors. So if the patient does respond to it, it would be a very favorable outcome. And if the patient doesn't respond to it, that definitely needs further investigation. And we cannot exactly say what could be the reason causing for that.
Okay, sir. I mean to say that whether it is like using an antibody, so it might have kind of severe allergic reactions or something which we are targeting.
So basically, this monoclonal antibodies have undergone several generational changes. Like it's not exactly what it was first initially discovered. So these changes have taken to reduce all the side effects or the non-target effects, and it has been utilized in by the clinic for a pretty long time. But again, if a patient actually have HER2 positivity, it's up to the clinician who actually have to look into the patient history and figure out if that there can be an allergic response, or if there can be a non-targeted response that can probably come from there. yes, that's something that the clinician has to look into, and this patient also need to follow up on a regular basis so that these side effect doesn't cause any other issues to the lifestyle or the life of the patient, basically.
Okay, thank you so much, sir. Yeah, thank you.